Hello, everyone. Today we'll be discussing the topic complications of living donor liver transplantation. Basically, this is a vast area because the living donor liver transplantation is a really complex operation. In addition to what can go wrong in a regular surgery, I mean, any major surgery like things like bleeding, cardiorespiratory complications, renal problems, and electrolyte disturbances. In addition, there's a lot of transplant-specific complications which can occur in LDLT. These include the list which we see here: the vascular biliary complications, infectious complications, graft dysfunction, neurological complications, and drug-induced complications. So among the vascular complications, the most dreaded of the vascular complications is the hepatic artery thrombosis. It is one of the most severe complications of LDLT. The incidence varies in literature. Publications vary between 2.5 to 9%. Generally, anywhere between 3 to 5% is an acceptable rate. The pediatric transplant, obviously, because of smaller vessels, the incidence of hepatic artery thrombosis is more in pediatric transplant, and it's a leading cause of morbidity and mortality. If you look at the literature, there's a lot of publications which analyze the risk factors for hepatic artery thrombosis. In the cadaveric scenario, you have elderly donors, prolonged cold ischemia time, smoker, and these two factors increase the incidence of hepatic artery thrombosis. Likewise, smokers, ABO incompatible transplants, surgical factors like when there's a lot of size discrepancy between the donor and the recipient artery, and when there's interval dissection needing multiple revisions. Like I said, in pediatric transplant, a lot of blood products usage and severe hypertension during the surgery, severe acute rejection and severe ischemia reperfusion injury. In this case, there's a lot of graft edema causing resistance to the arterial flow, and that can also predispose to hepatic artery thrombosis. Likewise, on the contrary, microvascular techniques, there's no level 1 evidence, but there's data to show in non-comparative studies to that doing the anastomosis by microvascular techniques using an operative microscope can reduce the hepatic artery thrombosis rates. Likewise, high volume centers, obviously, as the center volumes keep going up, the hepatic artery thrombosis rates have come down. The presentation is basically you have like early presentation of hepatic artery thrombosis and late presentation. Early is said within 4 weeks and late is after 4 weeks. In that presentation also, we can differentiate within the first 2 weeks and after 2 weeks. Basically, depending on the presentation, basically what happens is some degree of hepatic arterial collaterals form around the bile duct, and so within the first 2 weeks, these collaterals are not formed well. So it's very fulminant, and as time progresses, more indolent. So in the first 2 weeks, most of the time, ideally, the hepatic artery thrombosis should be picked up when the patient is asymptomatic. During the first 2 weeks, patient is in the hospital and is undergoing twice a day Dopplers. So it's either picked up on imaging when the Doppler radiologist says that there's no signal before the patient is symptomatic, or moment the morning or afternoon LFT show a slight rising trend as a part of a protocol. Doppler is done to evaluate, and then the radiologist picked up. This is the situations where it's picked up at the earliest. If it's the course is so fulminant that if it happens in the morning and is not picked up by evening, the patient is very sick. I mean, it's a fulminant course. Patient develops fever, liver necrosis leading to fever, the ascites worsens, the transmitters shoot up to drastic level. They go to more than thousands. The lactates go up to, they can go up very high levels, 8, 9, 10 kind of lactates. And there's a very rapid iteration, inotropes, acidosis. And so it's a very rapid iteration during the first 2 weeks. This is because the liver, the normal liver can have some collaterals like from the phrenic vessels and all that, but the transplanted liver, there's no arterial supply, is the exclusive blood supply. After the first 2 weeks, some degree of bile duct collateralization occurs from around the peribiliary. So the presentation is less severe. The patient does not have such a dramatic derangement of LFTs, though he may have liver dysfunction. And the patient's lactates don't go up so much. But in this after 2 weeks, what happens is basically the liver gets a dual blood supply, but the biliary system is predominantly supplied by the arterial blood. So in this case, the biliary bile duct necrosis with bile leaks, intrahepatic biliary necrosis with multiple intrahepatic abscesses. Eventually, the patient goes into sepsis and there is graft failure. So it's a more indolent course, but eventually the end result is, if it's not corrected promptly in the first 4 weeks, most of the time the patient succumbs. Either he has a retransplant or he succumbs. The late hepatic artery thrombosis, that is after 4 weeks, by which there's some degree of good collateralization has occurred around the bile duct. It's a relatively indolent course because in these patients, basically, you have mainly biliary issues. You have not just anastomotic strictures, non-anastomotic strictures, intrahepatic strictures, and patients keeps coming back with recurrent cholangitis, and they also become chronically ill, and they do have some sort of a chronic rejection. Mainly the chronic rejection is because they have recurrent septic episodes because of the biliary issues, and basically the immunosuppression is kept lower, because of which chronic low immunosuppression, they go into a chronic T cell mediated, lymphocyte mediated rejection, basically, which is secondary to biliary issues. So because of this, about 50% of the patients may be salvaged by interventional methods, but even in the after 4 weeks, a lot of patients may eventually need a retransplant. So the diagnosis is usually by Doppler, a routine Doppler ultrasound picks up an arterial signal, and the loss of it shows you hepatic artery thrombosis. But the Doppler can sometimes be false positive. Basically what happens is the Doppler can be false negative in the sense there's no arterial signal, but in the presence of severe arterial vasospasm, patient is hypotensive with multiple inotropes. In that case, the signal may be negative, false negative, and the sometimes patients with a lot of graft edema secondary to, like let's say, acute rejection or outflow obstruction, when there's a lot of graft edema, the Doppler may be falsely be negative. A better way is contrast enhanced ultrasound. It's now available in India. Basically, nano bubbles are given IV, and you pick it up again on ultrasound with a special software. So the contrast enhanced ultrasound is superior to Doppler if it's available. But eventually, every patient where there's a doubt, we need to do a CT angiography, which confirms the hepatic artery thrombosis. Celiac angiogram, we generally don't do the celiac angiogram because unless we are doing plan to intervene, a CT is good enough. The treatment options, basically within the first week, the option is only surgical revascularization, basically because if you try to thrombolize, there's a risk of, because there's so much of raw area and anastomosis, there's a risk of sudden massive bleed from there. So we have to go back in and redo the anastomosis. This could be a limited dissection. If there is only a limited dissection or limited unhealthy vessels, you can just redo the anastomosis. Sometimes if the distal vessel is badly dissected, then it may not even be possible to do it. But on the other hand, if the recipient artery is unhealthy, then you can go proximally, or if the entire length is unhealthy, you can do a conduit. Like if you have a cadaveric grafts, you can use the ileal vessels as conduits, or you can use a PTFE graft as a conduit. After the first week, 10 days, there is an option of endovascular revascularization. So you can go in with a catheter and do catheter thrombolysis, followed by angioplasty and a stent placement. Literature has shown in 50 to 60% of the cases this is successful. But if obviously you are unable to revascularize for some reason, or the patient is already gone on to develop severe hepatic necrosis and is unsalvageable, you might have to do a retransplant. Because of all these reasons, hepatic artery thrombosis is a very dangerous complication. The mortality worldwide is reported 1 out of 3. It's probably more in the Indian scenario, because unlike the Western scenario, where once a patient gets into hepatic artery thrombosis, he's put into super urgent listing. Anywhere in the country, the first cadaver that comes, the option is that it goes to this patient. But in India, in the living donor scenario, it is difficult to go for a super urgent relisting, and when the cadaver grafts availability is low, it's a more dangerous scenario. So the best thing in our scenario is to prevent it. This is done by meticulous technique, preparing your vessels very well, avoiding any intimal injury, microvascular anastomosis when feasible. It's a better, probably reduce the arterial problems. We in our setup, though it's not backed by level 1 evidence, in the risky anastomosis, we use alprostadil. We sort of use low molecular weight heparin and ecosprin as anticoagulants and antiplatelet agents to prevent thrombosis. And once these patients, they should be regularly Doppler should be done 12th hourly, and if there is any doubt, we should image aggressively to pick it up in the golden hour before the multiple liver dysfunction and liver necrosis and the sequelae set in. In other than hepatic artery thrombosis, there's an entity called hepatic artery stenosis. Basically, hepatic artery stenosis is when this is usually not within the first week, it's usually after the first week. The incidence is reported as 5 to 11%, but in actual practice, it's definitely much lesser than hepatic artery thrombosis. What happens is after the first week, the radiologist on his Doppler, he picks up a tardus parvus. That means basically, if you look at this, this is the normal Doppler. The upstroke is almost very steep and vertical. The systolic acceleration time is very short. In this, from the base to the peak, it becomes a much flatter graph. The systolic acceleration time is much more flatter, indicating some degree of stenosis. The SAT is more than 100 milliseconds. And prior to the stenosis, proximal to this anastomosis, you have a very high flow. So with these, when radiologist reports this, we confirm the diagnosis in an angiography once there is stenosis. If there's mild stenosis, less than 50%, we could probably leave the patient under observation. But if it's moderate to severe stenosis with associated liver dysfunction, it needs prompt intervention. Most of the time, by angioplasty and stenting, it suffices and we can salvage the patient. Other rare complications are hepatic artery pseudoaneurysm. This is the incidence is 0.5%. Basically, it's a problem of some issue with the hepatic arterial anastomosis plus adjacent sepsis. This happens when there's bilomas, bile leaks adjacent to the hepatic arterial anastomosis in the presence of systemic sepsis, and also in patients with fungal sepsis. You can get these arterial pseudoaneurysms. These can, most of the time, they occur within the first 1 month, but you do get patients presenting late, up to 1 year later. So the presentation can be, asymptomatic, detected on imaging, like a CT angio done for some other purpose, or it could be like the presentation can be with GI bleed, intra-abdominal bleed, or hemophilia. The management is same. Within the first week, we try to manage with, we have to go in surgically. Later on, we can try to manage by angioplasty and stenting. Another entity, which is an unusual entity and interesting, is the splenic artery steel phenomenon. In this, what happens is basically your radiologist tells you there's some degree of liver dysfunction. Radiologist tells you on Doppler that the artery is showing very poor diastolic flow with a high resistive index, so as to have a block. But when you actually do the angiogram, you see that the arterial anastomosis is patent and the artery is patent, but the blood is being siphoned off because of a large splenic artery or sometimes of a large GDA. So in that case, coiling the splenic artery or the GDA sort of revives the blood supply and patient improves. This is called splenic artery or GDA steel phenomenon. And the hepatic venous thrombosis, venous outflow obstruction is another complication after living donor liver transplantation. Basically, the neo-MHV thrombosis is something which is very unique to living donor transplantation. As I'm sure we've discussed before, in the right lobe graft, the segment 5 vein and the segment 8 vein are implanted into the PTFE graft. So we generally leave the middle hepatic vein for donor safety with the donor. The middle hepatic segment, the segment 5 and 8, their outflow needs to be, because they've been disconnected from the middle hepatic vein, we need to reconstruct them. That is very important to give the liver an adequate outflow, and this is usually done with either a cadaveric portal vein or using the portal vein of the recipient or a PTFE graft. So this MHV thrombosis is a fairly frequent occurrence. It occurs in up to 1/3 of the patients within the first 3 to 6 months after surgery. When it presents early, it is a serious complication. So when the neo-MHV thrombosis occurs early in the postoperative period, they can have a varied course. So some patients if you have a dominant right hepatic vein and a less dominant MHV, and with good collateralization, you may have minimal symptoms. The patient may have just mild hereditary derangements, or sometimes if there's a dominant hepatic vein with poor collateralization, then it can present in a very dramatic way. Basically, what happens is that in a dramatic way, in terms of the sudden jump of LFTs, the bilirubin and the enzymes go up, and suddenly you're suspecting something like sepsis or acute rejection or arterial issue, and then you do the CT and you realize that it's actually new MHP thrombus. So new MHP thrombus has a very varied course. It depends on basically which system, right? RHP or MHP is dominant drainage of the right lobe and the collaterals, and also how early it occurs. So eventually, many of these patients, when there's significant thrombosis, they behave like small foci. That is basically, one is the effective liver volume is reduced because the congested infarcted congestive necrosis happens of the segment 5-8 in some patients. And if there's no necrosis, even then basically what happens is there's a functional outflow obstruction. That is, the inflow is still high flow, but the outflow MHV is compromised. There's a functional outflow obstruction leading to liver congestion and graft dysfunction. On the other hand, when it occurs late, when the good collateralization occurred, and when it occurs after the 3-4 weeks, it is pretty well tolerated. Probably, the MHP thrombus is documented as 1/3, but we don't routine. If the patient is doing well, we don't routinely do aggressive imaging of the patient in the post-op period once they get discharged after the first 1 month or so. So the incidence of MHP thrombosis, late thrombosis, maybe more, but because it's asymptomatic, it's usually not picked up. Neometric thrombus is usually picked up on Doppler, is diagnosed on Doppler and confirmed by a triphasic CECT. LHV and RHV thrombosis in living donor transplant is very rare. Basically, it happens if there's some gross technical errors, like the complete graft has rotated, or a patient is severely pre-thrombotic, which has not been picked up on workup. But generally, it's a very rare complication. Most often, what we see is stenosis. This again, usually after the first 2 weeks, it presents. There is graft dysfunction, the bilirubin not settling down. There's persistent ascites which is not settling down, and the radiologist tells you that there's a monophasic waveform. See the normal Doppler, you have a triphasic waveform. You have two negative waves and one positive wave. So this is the triphasic waveform, two negative followed by one positive wave related to the right atrial movements. And this, when it becomes monophasic, and then the radiologist says that there's a high flow gradient across the hepatic vein and anastomosis on Doppler, then this confirmed on CT angio. Treatment of it remains basically, we go in, we measure the hepatic venous pressure gradient, and angioplasty followed by hepatic vein stenting salvages most of these patients. Portal vein complications, again, in the adult living donor transplant scenario, portal vein thrombosis is a relatively rare complication, but there are in specific scenarios, like in pediatric transplantation, because in pediatric liver transplant, an attenuated portal vein is a frequent finding, so you might have to do, vein grafts, and you have to go proximally, or there is kinks and all that, and sometimes a split liver transplantation, and also in patients with a preoperative thrombosis where you've done a thrombectomy and use that same vein. And sometimes with this complex reconstruction, like patients with portal vein thrombosis, where you've gone till the SMV splenic vein bifurcation and used a vein graft, either a PTFE or a native vein graft, or in patients with, you've taken a donor with two portal veins and you put in a Y graft. In these kind of complex situations, you can have portal vein thrombosis. Again, portal vein thrombosis, when it occurs early, it is a pretty catastrophic presentation. In the first 2 weeks, patient can present with massive ascites. Again, there'll be abdominal pain related to the bowel congestion, bowel edema. There is liver dysfunction, and you can have portal hypertension bleed, variceal bleed. So immediate diagnosis on Doppler, it's confirmed on a CT angio. When it occurs in the early post-op, obviously there is no option of thrombolysis because there is a risk of bleed. So you have to re-explore and redo the portal vein anastomosis. If there is a thrombus, you have to do a thrombectomy, or and put them on anticoagulation, or if it's a very unhealthy vein, you might have to put in a graft. But basically do that, and then patient remains on high dose of anticoagulation. When it happens after the first week, you have the options of thrombolytic therapy followed by anticoagulation. If obviously in the first couple of weeks, when this happens, you're not able to salvage the portal vein flow, then patient would need a retransplantation. Late complications are basically when the same thing occurs late. Most of the time when it occurs late, it's at the OPD basis. Patient is already an organized thrombus where the pain patient comes to your collaterals form. Mainly the problem is portal hypertension, which can be managed medically, or if there's significant portal hypertension, you can do tips to relieve it and put the patient on anticoagulants. So and next we come to the biliary complications. The biliary complications are rightly said to be the Achilles heel of liver transplantation. The incidence of biliary complications is is the most common complication. Incidence is about 10 to 30%, and the late onset strictures at 1 to 5 years needing re-intervention is about 20%. So almost 1 out of 5 is going to go on to form a biliary stricture. The incidence is probably more in the Indian scenario, where we don't have a cadaveric option. In the West, like something like when they have a lot of cadaver available, something a type 1 or a type 2, they would accept, but a type 3A, especially when there's a big gap between the right hepatic, right anterior and the right posterior, or a type 3B, they would reject as a donor. But in India, when we don't have the cadaver as an option and the donor recipient is very sick, we tend to accept more of these higher, more complex biliary anatomy, which lends itself to more biliary complications. So traditionally, because of these variations, the right lobe grafts are biliary complications are more than the left lobe grafts. The left lobe usually don't see much of variations. A duct size less than 4 millimeters is at a higher risk of stricturing, and a duct to duct anastomosis versus hepatic anastomy. So there's good data from some of the large centers like Assam to showing that when you have a hepatic angiostomy, the is better, especially with two ducts or smaller ducts. Hepatic angiostomy causes lesser bile leaks and lesser incidence of strictures compared to a duct-to-duct anastomosis, probably because in the traditional duct-to-duct anastomosis, because the dissection and all the duct vascularity is a bit impaired. But still most of the surgeons, we prefer to do a duct to duct because of the post-op. You have a chance of ERCP for re-intervention. That gives you the option of ERCP, which you don't have in hepatic angiostomy. And of course, during this transplant surgery, making a rule and doing another bowel anastomosis, you'd like to preferably avoid that with the risk of sepsis. So a lot of surgeons, despite these disadvantages, still duct-to-duct anastomosis are in vogue. And of course, patients with hepatic artery issues, hepatic artery stenosis, thrombosis, and ABO incompatibility, they are at high risk of biliary complications. The obviously in the early post-op it's leaks, and later on you form strictures. In the leaks, the identification of leaks is the presentation is not like in the regular patient, sudden abdominal pain and fever and all that. It may be more subtle. You may have sepsis features, low-grade sepsis features. You may have just graft dysfunction, non-improvement of enzymes and bilirubin, patient's bilirubin stuck. And then when you see the CT or MRCP, you see that there's a collection. And then when you do a PCD, you realize that it's actually a bile leak. So for some centers, for very early bile leaks, they may go in and try to re-explore and redo the anastomosis. But usually most of the time, by the time we go back in, it's all very friable. And most centers prefer managing this by a PCD within the first couple of weeks, and then trying to stent the anastomosis with an ERCP. Strictures, again, the strictures usually present a bit late. In the early post-op, you can have casts of the biliary system. Sometimes biliary casts can form, and they can sort of present with obstruction. But strictures usually take some time. These presents typically with LFT derangements, recurrent cholangitis, intrahepatic abscesses. But sometimes they may not be that easy to diagnose. Like in the regular patient or in the cadaver transfer, you may not have gross IHBRD on this thing, and it may be more subtle biliary dilatation, just loss of signal at the anastomotic site. Sometimes the decision making is difficult. We're not sure whether we're dealing with this with biliary obstruction. Sometimes we might have to do a liver biopsy to look for large duct obstruction and rule out rejection before we intervene. So when you have strictures, you have to differentiate between anastomotic strictures. They're usually at the site of the anastomosis, short segment, good prognosis, while non-anastomotic strictures higher up and they're long segment, multiple. These are usually associated with arterial issues, and they are poor prognosis. And most of the time, the ERCP, the strictures are managed by ERCP if you have a duct-to-duct anastomosis. And but many times you also need a PTPDB if you're not able to cross. And sometimes especially with the right duct anastomosis, the odd angulations and all may ensure that many times we use a rendezvous approach to cross a stricture. If you're not able to cross a stricture and the stricture persists, then obviously for the anastomotic strictures, at least surgical revision is an option. Though surgical revision for a cadaveric transplant is a much easier option, because you can go above the anastomosis into the left duct, use the Hep Quinard approach, and do an easy anastomosis, while it's a very technically challenging job for a right lobe graft in a living donor scenario. And then the next complication is acute cellular rejection. Most of the time, acute cellular rejection occurs within the first 6 weeks. 70% of them occur within the first 6 weeks. It's a fairly common complication. About 1/3, 20 to 45% of the patients have a single episode of, at least have 1 or 2 episodes of acute cellular rejection. But it's a usually easily manageable complication. The mortality is very low. In fact, some degree of an episode of acute rejection in the early postoperative period can help the organ develop better immunotolerance. So it is not a very serious complication, but still an important complication, especially in the Indian scenario, because the acute rejection, the stay is prolonged, the cost of treatment is prolonged, and especially in our scenario where we have multi-drug resistant bugs, because of the pulsing more than the rejection, the subsequent high dose of steroid and immunosuppression usage predisposing the patient to sepsis is a pretty significant complication. So at presentation, acute cellular rejection, most of the time, I mean, commonly patient is asymptomatic, patient is clinically well. It just shows the bili and the enzymes shoot up. And of course, patients sometimes can be symptomatic. Their ascites can go up. They can get low-grade fever, malaise, decreasing appetite, and general unwellness. The LFTs typically show increasing bilirubin and transaminitis and alkaline phosphatase. But compared to like other causes of graft dysfunction, usually the PT remains relatively unaffected, at least in the early part. But the lab, especially the living donor scenario, the lab and clinical parameters are not neither sensitive nor specific, because sometimes you can get without transaminase only increasing bilirubin. Sometimes only the enzymes can go up with a normal bilirubin. Usually later on the bilirubin goes up. So we can't rely on clinical diagnosis, especially in our kind of Indian kind of scenario where rejection treatment, empirical pulsing can give you put you at risk of septic complications. So initially, obviously, we do the Doppler, then we do a CT triphasic to look at all the problems, rule out collections, venous outflow obstructions, portal vein, hepatic artery issues, all that. We get a procalcitonin done to rule out sepsis. Also use your clinical judgment. And once other causes are ruled out, preferable always to do a biopsy before you treat for rejection. Reason is, basically, again, like I said, not to over-treat rejection based on empirical evidence. You do a biopsy. Most of the time, if there's mild rejection, you would not really pulse the patient, just increase immunosuppression, achieve a good TAC level, then settle down. Well, it's moderate to severe rejection, you might need to treat it. The biopsy in the early postoperative period, we do a transjugular biopsy because the liver is soft and a percutaneous route. There's a risk of sudden liver, when the soft liver can tear and lead to massive bleed. It's not safe to do it. So you can do a transjugular biopsy through the IJV and you get a good sample and safe also. It doesn't, when you do that, it doesn't matter what the prothrombin time is, what the platelets are. While later on, after a couple of weeks, you can do a plug biopsy. Basically, we do a percutaneous biopsy, ultrasound guided, avoiding the vessels, and then the biopsy tract is plugged with gel foam to prevent bleeding. So on biopsy, basically, we look at the predominantly lymphocytic infiltration by the Banff criteria. We look at the portal tracts, we look at the bile ducts, and look at the endothelium. And basically, the grading is from 0 to 3 for each one. And out of a score of 9, how much you get, based on that, you categorize as mild, moderate, and severe rejection. Once you have rejection, moderate to severe rejection, the treatment is pulse dose of steroids. The dose varies for an adult. It's about between 10 to 20 milligrams per kilogram. The dose varies between 500 to 1 gram. The traditional dose has been 1 gram for 3 days, followed by tapering. But currently, their data has shown that with lesser doses of pulsing also, you might get an equally good response with less complications of steroid usage and less risk of sepsis. So now it's a very subjective, tailored approach to treating rejection. It varies from center to center and patient to patient. We used dose as low as 500 and sometimes even 200, and just increase the TAC level and see the response. So essentially, but the treatment is basically increasing the pulsing with the dose of steroids. The dose can vary depending on the patient and center usage. And majority of the patients, 90% of them respond. In non-responders who are not responding to pulsing, options are of repeat pulsing and ATG and OKT3, anti-thymocyte globulin and OKT3. But it's always better to, because all these drugs usage puts them at risk of CMV, sepsis, and bacterial viral reactivations and fungal sepsis. So whenever you have such a dilemma, it's always better to rebiopsy and confirm that the rejection has really not responded before you go for this aggressive immunosuppression. So many times what you have is the patient we've had patients in which the enzymes and bili go up. We've pulsed the patient, and after pulsing, the patient's bili is stuck and the enzymes are stuck. So at that point, when we do a biopsy, if the biopsy shows the rejection has histologically responded, the inflammation has responded, most of the time just wait and maintain good TAC levels rather than repulse, and the patient will slowly settle down. If on the other hand you see brisk rejection, then you might need to treat the patient, go for a repeat pulsing or ATG. Another entity is chronic rejection. Basically, the liver has some immune privileges by various immune mechanisms, and it's a relatively immunoprotected organ. Like, for example, compared to, let's say, heart transplant or pancreatic transplant or kidney transplant, the rejection rates are much lesser in liver. The rejections are much easily treatable, and chronic rejection is very, very low. In fact, now with the modern immunosuppression, chronic rejection is less of a problem. Like I said, you do have these patients with biliary sepsis and arterial problems because of chronic recurrent sepsis. They're not put on much immunosuppression. Those kind of people go into chronic rejection and graft failure. But traditionally, the chronic rejection, there are two types. Basically, you have T lymphocyte chronic rejection, which is basically an immune-mediated graft dysfunction secondary to, mainly characterized by ductopenia. More than 50% of the bile ducts are lost. The DDs for this are arteriopathy or chronic CME infection. So this kind of chronic rejection, if it's identified early, it can be treated by increasing the immunosuppression. But if it's detected late, you might have to eventually, there leads to graft failure and need for retransplantation. And then another form of chronic rejection is antibody-mediated rejection. Basically, there's upregulation of HLA2 molecules, and the liver becomes vulnerable to donor-specific antibodies. This is another type of rejection, basically, when the patient shows features of chronic rejection, and on the biopsy, when you do C4D staining and use the donor-specific antibodies, there is evidence of we diagnose antibody-mediated rejection. Another entity specifically we commonly see more commonly in living donor liver transplant is postoperative allograft dysfunction. Basically, the problem, primary non-function, that means you put in the liver and the liver doesn't work. The enzymes keep going up to thousands, 5,000, 10,000, and the INR, patient goes to severe encephalopathy and dies. That is very rare in living donor scenario. But what you see is basically early allograft dysfunction in the living donor scenario, which usually sets in after first week. And it usually sets in after first week. And basically, this is associated with increased morbidity and mortality. The definitions of early allograft dysfunction vary. For the living donor scenario, this is the best definition is probably something published by Indian authors. Basically, persisting bili more than 10 mg% and INR beyond 1.6 for 5 consecutive days beyond day 7. Sort of, because and compared to the cadaveric graft, where the allograft dysfunction is defined between day 2 to day 7. In the living donor, depending on the patient's general condition and the graft size and the volumes, the LFT take much longer to settle down. So it's better to do this definition as with this current definition which we've developed in the Indian scenario: persistent bilirubin more than 10 mg% and INR more than 1.6 for 5 consecutive days beyond day 7. Basically, what does early allograft dysfunction indicates that there is some degree of inability of the graft liver function to meet the metabolic demands of the patient. So, step one for this is basically, once you have graft dysfunction, First thing, you have to rule out all the vascular challenges, the hepatic artery thrombosis, hepatic artery stenosis, portal vein outflow, new MHV issues, rule out biliary issues doing an MRCP, and rule out immune issues. You might do a biopsy to rule out rejection, rule out sepsis, doing cultures, procal, and assessing clinically. Once all this is ruled out, you have the allograft dysfunction, and it fits into the criteria. The commonest this thing we say is that basically a small for size liver. The liver is either actual volume is small, or because of a postoperative event, there's some degree of liver infarction occurs, and because of that, the liver is small for size, leading to a portal hyperperfusion injury, and that is supposedly the commonest reason behind postoperative allograft dysfunction. But in actual practice, it's much more complex. Many times the graft volume is enough, still they have a significant allograft dysfunction because the donor age, the recipient meld, or the amount of SIRS that he's having, so which reflects on his metabolic demand, the graft quality, the amount of steatosis in the graft, the kind of ischemia reperfusion injury, the warm ischemia time, and the ischemia reperfusion injury. And sometimes when the portal hyperperfusion, not directly, but because of some outflow issues, there is some degree of MHV not being reconstructed, or the MHV thrombosis, there's functional outflow obstruction because of which is either the outflow obstruction or too much portal perfusion. And sometimes you can have portal steal also leading to graft dysfunction. Basically, you have a low flow portal state, and then you have a portal steal phenomenon which leads to outflow obstruction. This is a potentially reversible scenario. If there is portal hyperperfusion injury, small for size, one option is obviously portal flow modulation by splenic artery embolization or splenic artery ligation. Then it's all supportive therapy. Just give it time, support the patient nutritionally, rule out sepsis, aggressively rule out sepsis, and maintain lowish immunosuppression so that it doesn't get septic complications. And it's a potentially reversible scenario. But if it doesn't improve, these patients have higher mortality. Infection is, of course, a major complication. Bacterial infections are mostly seen in the first 1 month. Patients with a high MELD, patients who had multiple sicker patients who had high MELD, nutritionally poor patients, patients who had multiple transfusions, patients who are sick post-operative allograft dysfunction, prolonged ICU stay, indwelling catheters, patients who had biliary complications with bilomas, and arterial complications with secondary biliary necrosis. These are the patients who are really prone to bacterial infections. The strategy would be reducing immunosuppression and early delining. We try to, by day 3, we try to get all the lines out, and aggressive therapy using broad spectrum antibiotics. So, most of the time we have multi-drug resistant organisms in our setup. So they may be carbapenem resistant. Then we rely on antibiotics like tigecycline, colistin, or zavicefta and aztreonam, and also avoid aggressive empirical pulsing like we were discussing previously. So in the Indian scenario compared to the West, the multi-drug resistant gram-negative sepsis is a major challenge, because in the West, they're still getting away using augmentin peptides in most of the patients. In India, moment the patient has a slightly prolonged hospital course, any hospital-acquired infection, we have multi-drug resistant drugs, and it's a scary scenario. So sometimes we just feel if this continues like this, whether we'll be left with any antibiotics left to treat hospital-acquired infections in these really sick patients. Viral infections are another common thing. CMV is, of course, a very big concern. CMV infections occur after the first 1 month. Usually after the first 1 month, they present as a CMV illness, some sort of CMV illness which presents with fever, malaise, arthralgias, and leukopenia. Or you can have CMV disease, where invasive CMV infecting the lung, causing pneumonitis, liver causing hepatitis, enterocolitis, or you can have disseminated disease, or a chronic CMV infection can present like a chronic rejection. Patients who are at high risk are patients who have the donor is CMV IgG positive and the recipient is IgG negative. Patients who have been pulsed with steroids, or patients who have ATG. So general strategy worldwide is for 3 to 6 months, we give valgalinic cyclovir prophylaxis. That's the usual strategy, while some centers follow an expectant prophylaxis. That means they don't put the patient on valgalinic cyclovir to avoid its side effects like renal toxicity, but basically they follow up the patient with monthly CMV titers. If anything, any adverse event occurs like fever or deranged LFTs, they aggressively do the CMV serology to to identify CMV and treat it at the earliest. Once the infection is identified, treatment usually consists of IV ganciclovir or valganciclovir. Then other viral infections, you can have HSV reactivation coming with the oral or genital sores. Some centers also routinely use acyclovir prophylaxis in the first week, but it's not so common. So a lot of centers don't use it also. EBV reactivation is an issue. This can lead to infectious mononucleosis, flu-like illness in the early postoperative period, but in the long term, it can cause PTLD. Fungal sepsis is a major issue following post-liver transplant, especially again in the sicker patients who had a prolonged ICU, multiple antibiotics usage, patients who've been on high immunosuppression, pure nutritional status, the retransplanted, and the sicker patients, the incidence is as high as 5 to 20%. Among the sepsis, disseminated candidemia is the most common, Candida non-albicans, and aspergillus is the incidence is relatively the rarer infections still common are aspergillus, which can affect the lungs and the CNS, and you can have mucor. I've seen over the years mucor of the one case of small bowel mucor, and one case of colonic mucor, one case of gastric mucor, especially common in diabetics. So mucor is also present. So it's very important by aggressive imaging and blood cultures, early tissue biopsies, and galactomannan assays, that kind of thing, to diagnose fungal sepsis early. And these patients who are at high risk are usually, fluconazole doesn't suffice. You need to go into higher antifungals like the echinocandins, like the caspofungin, anidulafungin, micafungin, or in case it's mucor. So basically, you have to go beyond, like drugs like voriconazole for aspergillus and candida, or drugs like isavuconazole and amphotericin for mucor. So you have to early diagnose and treat with broad spectrum higher antifungals. We also have to rely on cultures because the fungal organisms are resistance is quite common. The pneumocystis, there are a lot of other opportunistic infections. Pneumocystis carinii, now with the Sepran prophylaxis we give till 3 months, its incidence is very much less. Likewise, the cryptococcus infections, usually in the first 1 month you can get cryptococcus pneumonitis, and then third month CNS infections, Legionella pneumonia. There are a lot of other opportunistic infections which we need to be aware of and diagnose and treat promptly. One specific complication to the transplant scenario is, of course, the drug toxicities of the immunosuppressions, the tacrolimus, cyclosporin, the calcineurin inhibitors have a lot of CNS toxicities, which may range from simple headaches to seizures to delirium and disorientation. And they can cause electrolyte abnormalities such as hyperkalemia, dyslipidemia, hyperphosphatemia, hypomagnesemia. We need to monitor for these and correct them promptly. Then the renal problems, of course, the renal toxicity is a major issue with the calcineurin inhibitors. You can get renal tubular dysfunction. You can get reversible azotemia, which immediately improves after you stop the calcineurin inhibitors. But on the long run, also calcineurin toxicity, long-term calcineurin toxicity can cause chronic renal dysfunction and CKD-like picture. These patients need to be taken off. You have to go a calcineurin sparing strategy and use mTOR inhibitors like everolimus and sirolimus. Mycophenolate can cause GI toxicity, diarrhea, nausea, stomach upset, and can cause pretty severe bone marrow depression sometimes. So these patients need to be monitored for this. And steroids, of course, we know the steroids are used with hypertension, bone disease, diabetes, muscle weakness, growth retardation. So generally, now the strategy is to stop steroids by 6 weeks in liver transplantation. We avoid excess use of steroid, unnecessary empirical pulsing, and taper the steroids rapidly. And in the early post-op also, especially in the Indian scenario, people are using lesser and lesser doses. Initially, in the cadaver in the West, they give 250 milligrams on day 1 and 125, 80, 60 like that. While in the Indian scenario, we are actually starting with only 40 mg Vicelon on day 1. So steroid sparing is very important. So lastly, the neuropsychiatric problems are a major issue post-liver transplantation. The incidence is as high as 50%. You can have a wide variety of neurological, neuropsychiatric issues post-transplant. They can be seizures, varying degrees of delirium, and altered levels of consciousness. These are, of course, can be multifactorial. They can be non-specific, multifactorial, like secondary to drugs, like the calcineurin inhibitors, the sedation we give, then the lung respiratory issues, hypoxia, hypercarbia. They can be related to hepatic encephalopathy secondary to cholestasis or early allograft dysfunction. They can be related to septic encephalopathy, or they could be related to electrolyte problems. So all these can cause a wide variety of neuropsychiatric problems. Then you have specific problems like central pontine myelinolysis. The incidence is about 5%. Basically, there is demyelination of the basal ganglia, the pontine and other basal ganglia. This is especially seen in patients who are hyponatremia and patients who are nutritionally poor. The patients who had a lot of fluid fluctuations during their transplant, and HRS patients. Actually, if on imaging, if you routinely do MRIs, you can, the evidence of CPM is seen radiologically in more patients, but clinically not many are symptomatic. But in the patients who are symptomatic, the diagnosis is by an MRI. So CPM can be from a very mild illness, mild disorientation, confusion state, to very severe like seizures, and patient can be almost near comatose. When it's mild illness, the prognosis is good, but severe CPM, it's usually not reversible, and it's very poor prognostic factor. On the contrary, you have things like posterior reversible encephalopathy syndrome, which is a completely reversible condition characterized by seizures and visual disturbances, which immediately reverses after stopping the immunosuppression, reducing the immunosuppression. CNS infections, like we've discussed, aspergillus, cryptococcus, other bacterial and fungal infections of CNS can occur. And drugs toxicities per se can lead to a lot of neuropsychiatric disturbances. Calcineurin inhibitors, the commonest are headache and tremors, and they can have seizures, especially when combined with hypomagnesemia. Steroids can cause a lot of emotional, when patients who are pulsed and on high doses steroids, steroids can precipitate emotional labile states, and they can precipitate mania. Likewise, anxiety, depression, and ICU psychosis. So all these patients are in the ICU for prolonged. Patients who have had complications, patients who are sick pre-op, they're in the ICU post-op, isolated for a prolonged period of time. So anxiety, depression, and ICU psychosis are major issues. So these are basically the early complications after living donor transplant. To sort of summarize, there's a wide variety of complications. Vascular and biliary complications are more common compared to the DDLT scenario. The decision making, especially in the early allograft dysfunction, in acute rejection, in biliary obstruction, these kind of scenarios, decision making is more complicated in the living donor compared to the DDLT. In the Indian scenario, the complications is made more challenging because we don't have a retransplantation option quite often, and the sepsis is also multi-drug resistant organisms. So the best strategy would be to sort of avoid these complications as much as possible. Thank you.